I feel pretty good. Now we do accessory organs. So what are the accessory organs of the GI system? Liver, gallbladder, pancreas. So we're going to start with liver, the big one. Is the liver the biggest organ in your body? No? What is?
Skin.
Skin. So liver is the largest solid organ in your body because skin ain't that solid. It's kind of stretched all over the place. What's the liver's job? What's his main job? There are two of them. So main job number one, filter blood. What does it do with what it filters? Oh, come on. You guys know the answers here. You're just pretending like you don't. Say again?
What's the question?
What does your liver do with what it filters? Think alcohol. It metabolizes it. So it's going to filter the blood and then metabolize the stuff in it, including drugs. What was that? That is part of what the first pass effect is, yes. So, do you remember from Pathopharm 1 the series of enzymes that are present in the liver that do this? No, I was scarred.
CYP.
Yeah, cytochrome P450 or CYP. Whew. Okay, so that's one of the liver's main jobs. What's another main job of the liver? So it breaks stuff down. What else does it do? It makes stuff. And I heard someone say proteins. So proteins are one of the things it makes. Name 5. I can't even name one.
Albumin.
Okay, albumin. Got one. Give me another one. Okay, it makes bile, but that's not protein, that's stuff. So yeah, we will talk about that in a moment. So, albumin was one. Give me another one. Fibrinogen. All right, give me another one. Angiotensinogen. Mannose-binding lectin, CRP. Okay, I got no idea what those things are. Very sad. All right, so it makes stuff. Now, the last, and then it also makes other things, like it makes triglycerides, it also makes glycogen, it stores glycogen, things like that. And then the third one, and it makes bile. Now, there's a few components of bile, but what gives bile its name? Bilirubin. And what is bilirubin? I don't know. When have we looked at bilirubin in the past, in Pathopharm 1, test 5? What was test 5? It was hemoglobin and clotting. The breakdown product of hemoglobin eventually is bilirubin. Oh, yeah. So if you're destroying red blood cells, bilirubin levels will go up, right? Okay. So bilirubin is going to be conjugated by your liver. So you've got what they call direct bilirubin and indirect bilirubin. So direct bilirubin is conjugated by your liver, ready to be excreted in your bile. Indirect bilirubin is the raw stuff that comes out of red blood cells. So, in order to get rid of bilirubin, what does your liver have to do? Conjugate the bilirubin. What's conjugated bilirubin? What's the other name for it? Direct. And what's the name for unconjugated? Indirect. So it's the same. In, un, and then with no prefix, direct, and conjugated. So if you have elevated bilirubin, one possibility is you're making more of it than usual. What would that be an indication of? Red blood cell destruction. What's the fancy name for that? Hemolytic anemia. Another possibility is that your liver is not conjugating it correctly. That can happen during liver failure or other liver dysfunction. The third possibility is it's conjugating it, but it's not being excreted properly in the bilirubin. And that could be because either the liver isn't excreting it or there's a bile blockage.
It's not being excreted properly in the bile, right?
Yes. You also have bilirubin present in your feces, by the way. Because where does the bile go? Think about it. Where does bile go? In the digestive tract. And so the bilirubin gets excreted. That's what makes your feces kind of brownish reddish color. Without the bilirubin, feces are gray. They call it clay colored, but one of the problems with clay is that in some places clay is gray and other places clay is red. So which one is it? Gray. So that's typically, like if you go into pediatric nursing, if they've got gray colored stools, that's a sign that bilirubin is not being produced. So it's a biliary obstruction. Does that make sense? Okay. So what are the three possibilities for why you have high bilirubin? Hemolytic anemia, liver not conjugating, and not being excreted in the bile. So when it comes to evaluating the function of the liver, bilirubin is an important part of that. Now, if you've got high indirect bilirubin and the blood counts are normal, what's the most likely problem? Sorry, yeah, I said that wrong. Let's erase that. Okay, I'll do it on the board for myself. You can follow along. So your total bilirubin is high. And your direct is low. What does that tell us? It's not being conjugated. The problem is the liver what? Is failing to conjugate. Now, if they're both high, total and direct, what does that tell us? That is not being excreted properly. And this is assuming that the CBC is normal. If your CBC is low, the blood counts are low, then we're going to assume it's hemolytic anemia. Does that make sense? All right. So when we evaluate the liver function, one of the things we're going to evaluate is bilirubin. All right. Now, let's go back up here to metabolize stuff. As the liver metabolizes stuff, what's going to build up in the liver? Waste products. And what's the fancy name for a waste product of metabolism? Metabolites. So, metabolism leads to metabolites. And because it's occurring in the liver, where do the metabolites build up? In the liver. If a metabolite is toxic, what happens?
Damage the liver.
The liver can become damaged. How would we know if the liver is being damaged?
Or the yellow eyes.
The what?
Like when you have jaundice and stuff like that?
Way late. That's
Gray stool.
jaundice is increased bilirubin. That's a way late sign.
Gray stool.
Nope. Let me ask you this question. If your heart is being damaged, how would you know?
The cells are pouring
The cells are leaking their stuff out. What stuff do we check?
Enzymes.
Enzymes, cardiac enzymes like troponin. Well, what,
Hepatic enzyme.
liver enzymes. What are the liver enzymes that we would check? AST and ALT. I did that one backwards. It's usually AST first, then ALT. Sometimes you'll see SGPT and SGOT. Those are older names for AST and ALT. So when those enzymes are elevated, that is a sign of liver inflammation, which means damage is occurring to the liver. Very common in alcoholism, very common in hepatitis, and very common with drug-induced inflammation, which is why you want to check AST and ALT with patients who are taking statins. All right. So in terms of liver function, we've got bilirubin levels, we've got enzymes, and then we have something else, which is stuff that it makes. And the main stuff it makes is albumin in terms of protein. So if albumin levels are low, what does that tell us?
The liver is not functioning properly.
The liver is not making proteins properly. And that could be because of two potential problems. What are they? What do we make proteins from? Where do we make proteins from? Oh, come on. You haven't forgotten your principles of chemistry that fast.
It's been a while.
Who never learned it?
The amino
Yeah, all of that is involved, but I'm just really thinking, like, what's the building blocks of proteins? Say it again. Amino acids. Right. And where do we get amino acids from?
Our diet.
Food. Oh, right. So one problem if you're not making enough protein is you might not have enough amino acids because you're not eating enough protein. So protein poor diet may be a cause. What's the other big cause? Okay, so sure. So either you're not eating it or you're not absorbing it. But now on the inside, what's the other big reason why we don't have enough albumin?
Liver.
Liver what?
Damage.
Liver failure. So liver is failing to produce albumin. So this is usually a fairly late sign of liver failure. It's not going to occur for a while. Now, most of the liver failure in the United States is not acute liver failure. It's chronic liver failure. So it's going to take, 10, 20 years to develop. So you're not going to see low albumin for 10 to 20, 30 years. When will you see the liver inflammation? Early on.
So do you look for the inflammation or for the enzyme?
You look for inflammation by looking at enzymes. The enzymes are a sign of inflammation. Yeah. All right, so now that we've discussed what the liver does and how we evaluate some of the labs.
Question. You said that the chronic takes like years to find it, but for the inflammation, how long did you say that you would start creating those enzymes to show that?
It depends on the source of the inflammation. So if your source of inflammation is, say, hepatitis C, pretty early on. If it's alcohol, it might take a while. If it's drugs, it could be immediate. So it just depends. All right, so let's talk about what happens when you have inflammation. Or, no, it's not. Let's talk about the sources. So first of all, hepatitis. The number one thing when a person has elevated liver enzymes, AST, ALT, is we've got to see if they've got hepatitis. Why is that? What's the number one cause of liver failure in the United States? Not alcohol. Hep C. Now, can we treat Hep C? So if they have Hep C and we treat it, what will that do to their risk for liver failure? Decrease. What's the number one cause of liver cancer in the United States? Hep C. What will it do to the risk of liver cancer? It'll lower it. So that's why it's so important that when a patient has elevated liver enzymes, first thing we want to think is, could this be hepatitis? Now, if we just put them on a medication that can damage the liver, and they were normal before the drug and now they're not, we don't have to check for Hep C. But if there's no changes to their drugs, that they've been on something that can damage the liver, they just happen to have elevated liver enzymes, what's the first thing we have to do? Check for Hep C. Well, just hepatitis in general. So 3 main types of hepatitis. What are they? A, B, and C. There are others. We're not going to talk about them in this class because they're even more rare. So just reviewing back from Pathopharm 1, you need to know, is there an effective enzyme? Is there an effective immunization? What is the route of infection? What is the pattern of disease? And how is it treated? So, for Hep A, what do you got?
There's a vaccine.
There is a vaccine. What's the pattern of it? What is the route of infection? Fecal-oral. What is the course of infection? It's acute only. And then the patient either dies or gets better. General time frame is about 2 to 3 months. Hep B, is there a vaccine? Mm-hmm. Yes. What's the route? It is bloodborne, but the number one route of transmission is sexual contact. It is a sexually transmitted infection, and also a bloodborne infection. What is the time course? Okay, so most of the time it's going to be an acute illness. It takes 2 to 3 months to recover, and about 10% of patients will go on to become chronic. Hep A is 2 to 3 months.
To recover?
To recover.
But it's an acute illness.
Yes.
Do they go chronic?
No, Hep A is not a chronic. Hep B can be chronic about 10% of the time. If the Hep B is contracted from the mother during delivery, the chances that the baby will become chronic skyrocket. And that's why we give immunizations to infants, although it doesn't necessarily make sense in the United States where we don't have endemic Hep B. In the Asian Pacific countries, like the Asian Rim countries, Pacific Rim, that's where there's a much, much higher rate of Hep B infection in the country, in those areas. So there it makes a lot more sense. All right, Hep C. Is there an effective immunization? No. What's the route of transmission? Primarily blood contact. Possibly from sexual contact, but primarily blood contact. What is the pattern of infection? The time course. It's 99% chronic. Patients will sometimes have an acute onset illness, but it's relatively mild compared to Hep A and Hep B. So instead of several months, it's usually just a week. So a lot of times patients will think they had a flu and in reality it was their acute Hep C. As far as treatments go, in the old days it was interferon plus ribavirin, but the big problem with that was risk for depression. Nowadays we have newer drugs like sofosbuvir, Sovaldi, and those newer drugs, instead of having to treat the patient for 6 months to a year, we treat them from 8 to 12 weeks, so 2 to 3 months, and the cure rate is much higher. The reduction in viral load is sustained through time, so after they stop the drug, their viral counts stay low for a long period of time, and much less risk of adverse effects. All right, any questions about the hepatitis patterns?
I just want to know the old treatment.
Oh, interferon plus ribavirin. Sovaldi. That's the brand name. The generic is like sofosbuvir. Something like that. Yeah. There are other newer drugs as well. That's just the one that's coming to my brain. So, now, as far as testing for hepatitis, the first thing we typically look for is immunoglobulins. So you can have Hep B or Hep C antibodies. And those are typically, now they'll call them AB. And those can occur in either what's called surface or core. Surface is on the outside of the virus, core is on the inside of the virus. So, with the hepatitis antibodies, you can look for either surface or core, and that will have either a little S for surface or a C for core. Then, if those are positive, then what you can do, so let's say that it's positive for Hep C and it's negative for Hep B. Then the next thing you can do is look for Hep C core and surface antigens. So antibodies, AB, antigens, AG. If antigens are present, what does that tell you? If antigens are present, what does that tell you? They've got it in their body right now. They have virus inside of them. So the antibodies tell us has the immune system reacted against it. The antigens will tell us if there are current viruses inside the patient right this moment. Now, in addition to that, you can also do what's called viral load. What does viral load tell us? The number of viruses that are present. And viral load is the primary target of drug therapy. What is the goal of drug therapy? To reduce viral load, hopefully down to 0. All right, any questions about hepatitis? Now, other causes of hepatitis that we need to mention, we talked about drugs. So if they have inflammation from drugs, what should we do? So liver inflammation, AST, ALT are elevated. If it's from drugs, what should we do, if possible?
Lower the dose.
Lower the dose or take them off the drug. Another common cause is alcohol. What should we do there? Encourage alcohol cessation. This is not a course about addiction, but we do need to mention addiction ever so quickly. So what are the two main paradigms, ways of thinking about addiction?
It's a disease.
It's a disease, or
It's a learned pattern of behavior.
it's not a disease. So What's interesting is that belief in the disease model of alcoholism is actually associated with increased recidivism. What does that mean? What is recidivism? Failing treatment, going back to drinking. If you believe that you have no control over it, it's a disease and it has you, well, if you drink, was it your fault? You couldn't help it. It's a disease. Whereas if you believe that it's a behavior that you can control, you're more likely to actually control it. So what were the three components of the modern addiction theory?
Learned behavior.
Okay, learned pattern of deep behavior,
Exaggerated now.
exaggerated sense of now, decreased future. And the third one, ego fatigue. I think in the video I called it executive fatigue.
Yeah.
And that's where you just get tired of making decisions. And so the best way to help yourself there is to change your environment so that you don't have to be saying no all the time. So if you drink only in social situations, what do you need to do? Change the type of social situations you put yourself in. If you only drink when you're around certain people, what do you need to do?
Stop hanging out with
Avoid those certain people. But it's my wife. Well, yeah. So that's the idea behind ego fatigue. And so we're not going to go into alcohol treatment other than to say that it is possible. We did talk about detoxing from alcohol, and we talked about benzodiazepines. And so you've got the stages of withdrawal. I don't think that's on your test, but it might be worth knowing the stages of withdrawal. For life, you know. And how do we reduce the risk of delirium tremens?
Librium.
What is Librium?
That's benzo.
It's a benzodiazepine. So Librium is often used for it, chlordiazepoxide, but it could be any, not any, but it could be any of the benzos that are used for that sort of thing. So it could be Ativan or diazepam as well. All right, so that's alcohol. Now, what is the number one cause of liver inflammation in the United States?
Hep.
Nope, it's not hep.
Alcohol.
It's not alcohol. It's steatosis, which is another way of saying fatty liver. It's also called non-alcohol related liver inflammation.
That's number one cause for inflammation.
Number one cause of liver inflammation in the United States. And what causes fatty liver? You'll never guess. Obesity. Being a fatty person. As a former fatty person, I can say that. You know, today's modern, you can't fat shame, you can't body shame. Well, okay, we shouldn't shame anyone, but saying, hey, look, you're overweight, it's going to impact your health, you'd be a healthier person if you lost weight, that is not body shaming. Even acknowledging that, hey, you might look better if you lost some weight too, that's not body shaming. Now, in telling this to a group of young girls, I do understand that there's some risk of eating disorder and all that, but the vast majority of people, even with eating disorders, tend to be more overweight than underweight. So, how do we reduce the risk of steatosis?
Losing weight.
Maintain a normal, healthy body weight. So, if the person is overweight, what should they do? Reduce weight. What's the best way to do that? What are the three major components?
Calorie restriction.
Calorie restriction,
Increased protein.
increased protein,
Weight.
and weight or resistance exercise. You guys are so smart. All right. So that's the steatosis. All right, now what we're going to do is we're going to skip ahead 20 years into the future when the person has liver failure. And we're going to talk about liver failure. Now, as we replace normal functioning tissue with scar tissue, we're going to end up in what's known as cirrhosis. Cirrhosis is a scarred, small liver. So an inflamed liver is big. Eventually it becomes small and scarred. What's that called? Cirrhosis. Because the normal functioning tissue has been replaced with scar tissue, it's going to be harder to push blood through the liver. So what is the vein that goes into the liver for filtering? The portal hepatic vein. If it's harder to push blood through, what's going to happen to the pressure inside the portal vein? It's going to increase. So portal hypertension. Increased pressure inside the portal vein. Now your body's going to try and do something to get rid of that excess pressure. So it's going to start growing collateral veins. Hypo. So hypertension. Yes. Portal hypertension. So the pressure in the portal vein is going to be elevated. What is that going to do to the flow of fluid in that area? Going back to fluid physiology. Hydrostatic pressure, osmotic pressure, stuff happens on the arterial venous side. Do you remember all that stuff from Pathopharm 1?
Yeah, what are you asking about? You say with the collateral?
So, we'll hold off on the collateral for a moment. So, you've got a liver, and you got a portal vein going into it, and we've increased the pressure inside it. What's going to do? What's going to do? What's going to happen? What's going to happen? Likely. Why is there more pressure in here? Because there's more blood volume. So what does that excess blood volume have a tendency to do? Ooze out. Right. Okay. So at the same time, your patient is going to have lower albumin. What is albumin primarily responsible for in this situation, in this context? Plasma-osmotic pressure. So we have an increased desire to push blood out. We also have a decreased osmotic pressure to pull fluid back in. So what's going to happen is we're going to get an accumulation of fluid on the outside of the portal vein. So we're going to have a collection of fluid where? In the abdomen. And what's that called? So these two things lead to ascites. In your notes, I've given you a couple pictures of ascites that are like massive, like huge amounts of ascites. Now the ascites is going to put pressure on your abdomen. And your body wants to relieve this excess pressure of both the ascites and the portal hypertension. So it's going to start to grow new veins that go around the liver. What's that called? When you grow veins or circulation around something? Collateral circulation. So there's three basic places we can go to get away from the ascites. One is the surface of the abdomen. So we're going to grow large veins on the surface of the abdomen, and that is known as caput medusa. And I've given you a nice picture of Medusa in case you haven't read Percy Jackson and the Olympians. You can tell we've got a literary genius here. Yeah. So that is one place, caput medusa. Why is it called caput medusa? Because the tangled veins on the surface look kind of like snakes, so head of Medusa. Another place it can go is inside. So where inside could we go? Inside the body. Where's a tube that's available? The esophagus. So that's going to be called esophageal varices. So varices, plural for varix, or varicose vein. So varicose veins inside the esophagus. Now, those are at higher risk of rupturing. Every time you eat, they're going to be scraped by the food. If they rupture, the chances the patient will die are very high. And what will the main symptom be, or sign?
Coughing up blood.
More than coughing up blood, vomiting up blood. And it's kind of like a horror movie, yeah. So there was a patient once who vomited inside an elevator. And elevators sometimes have mirrors on them. Yeah, the entire inside of the is just like coated in blood. Yeah. So now, what's the ordinary treatment for bleeding? How do we stop bleeding under ordinary circumstances? Apply pressure. How do we apply pressure to the esophagus? We're going to have them swallow a balloon and then pump up the balloon. And that's called a Blakemore.
A what?
A Blakemore. It's not going to be part of your test, but...
That's cool, though.
No, why do you tell us these things?
It's confusing because it's like, which part is...
Well, when I tell you that's not part of your test, then that's not part of your test. Otherwise, it's fair game. So, what do we do for esophageal varices when they rupture? Blakemore, which is swallowing a balloon, and that applies pressure to the inside. But extremely life-threatening when rupture. The third place that we can go is a tube on the other end. So hemorrhoids. So the three collateral vein locations: surface of the abdomen, caput medusa, inside the esophagus, esophageal varices, and then the rectum, varicose veins.
So, you might not have the time to answer this, okay, so why do people get hemorrhoids on like when they give birth?
Hemorrhoids when giving birth is because of straining.
Okay, this is different.
Yeah. Yeah, it was still a hemorrhoid, but a different reason.
Different reason.
Yeah. These hemorrhoids are caused by the need for collateral circulation. Now, if you're building all these collateral veins, that should resolve the portal hypertension, right? Say right.
Right.
Right, but it doesn't. And the reason it doesn't is because of something called splanchnic artery dilation.
The portal hypertension.
It doesn't reduce the portal hypertension because of something called splanchnic artery dilation. Now, splanchnic is a fancy way of saying gut. So the gut arteries dilate, and the reason for that is because of the problem with metabolizing. Because the liver isn't filtering blood properly and it's not metabolizing properly, there are breakdown products that aren't being broken down, and some of those products cause dilation, particularly of the gut arteries. That is going to do two things. One is it's going to lower the patient's blood pressure. Second is it's going to increase portal volume. What does increased portal volume do to blood pressure in the portal vein? It's going to increase it. So that's the driving factor behind that portal hypertension, and it's why it doesn't resolve with your collateral veins. Now, your patient's got low albumin. What does that do to your osmotic pressure? Decreases it. What does that do to your blood volume? It's going to decrease your blood volume through edema and ascites. So your patient has low blood pressure and low blood volume, but they have fluid overload in their lower limbs and in their gut. But what's their blood pressure? Low. So they've got fluid overload. It's just in the wrong place. Where does it need to be? It needs to be in your arteries. But where is it instead? The portal vein, edema, and ascites. Because of that, they're going to be wanting to retain fluid. So they're going to have, I'm running out of space here. They're going to have elevated renin-angiotensin-aldosterone activation. What's the purpose of the renin-angiotensin-aldosterone activation in this case? To maintain blood pressure. Now, if you give them an ACE inhibitor, you're going to bottom out their blood pressure, so we don't do that. But what we will do is we'll give an anti-aldosterone, either aldactone or a eplerenone. And that will help to reduce some of the blood pressure. Well, sorry, it'll help to reduce some of the fluid retention. Yeah, it'll help to reduce some of that fluid retention. The other thing that we can also do is we can give a beta blocker. And the reason for the beta blocker is that it will help to reduce the amount of renin-angiotensin-aldosterone activation. Because what is it that tells your body to your kidneys to release renin? Okay, so one is lack of blood flow, and the other is epinephrine. So giving beta blockers can also help. All right. The other thing that tends to happen is we have elevated levels of ammonia. So under ordinary circumstances, when your body metabolizes proteins, it releases ammonia. The ammonia is toxic to your body, so we've got to do something with it. And that something is your liver turns it into urea nitrogen. And you know that as BUN. And then BUN gets excreted in your kidneys. Urea nitrogen, which you know as BUN, blood urea nitrogen. Oh, right. And then BUN is excreted by your kidneys. It's why we call urine urine, because it's got urea in it. So, what is the breakdown product of protein metabolism? Ammonia. What does our liver do with it? Turns it into urea, which is excreted by your kidneys. But when you have liver failure, what happens to the ammonia? It stays ammonia. More of it does anyway. And that leads to hepatic encephalopathy. So patients will be confused. They can have ataxia and they can have coordination problems. And one of the signs of it is called asterixis. So in asterixis, what you do is you ask them to hold their hands out with their fingers pointing up, and their hands will flap. What's that called? Asterixis. Aster, ix, is. Eating high protein meals will increase ammonia levels. So it's very, very common after certain holidays to have people coming in admitted with encephalopathy. Can you name the number one culprit? Thanksgiving, Turkey Day. So you can have some turkey, you just can't have as much turkey as you want. But you might as well not have any then. Yeah, whatever floats your boat. It's your life. Now, when a person's got elevated ammonia levels, we can reduce them with lactulose. So remember last class we talked about lactulose briefly, and we said it was what kind of laxative? An osmotic laxative. And what it does is it draws ammonia into the gut, and then you poop it out. So the treatment for elevated ammonia levels, encephalopathy, is going to be lactulose. And then what you want to do is want to make sure that they poop it out before it can be reabsorbed. So the way that we're going to do that is lactulose plus tap water enemas. Basically flush out the colon.
They said that you could use enemas to treat constipation too.
Yes, you can use enemas to treat.
What is it?
An enema is when you put liquid into the colon.
Oh.
So there's different types of enemas, but the usual use of an enema is to cause evacuation of the bowels. So in this case, we're going to make them get rid of it before they have a chance to reabsorb any ammonia. So typically the order will be something like lactulose however many times a day and tap water enemas until clear. Better off just not eating that turkey, if you ask me.
Why don't you want lactulose to stay in? Why don't you want it to digest? I'm sorry.
No, the lactulose will get pooped out. It'll draw ammonia into the gut, and you want to make sure that ammonia gets excreted and not reabsorbed.
Gotcha.
So the way you do that,
Yeah. So it doesn't cause reabsorption.
Right.
Chill. Sounds good.
okay. I feel like there's something else I'm missing on the liver thing. So, am I missing anything from your slide? You're supposed to look at your slide.
Oh. I thought he was asking me after.
Specific, portal-vein, etiology, post-hepatic, pre-hepatic,
Splenomegaly.
blood vexilla, ascites, hepatic, and so.
I think I got it.
I think you did.
All right. So,
Oh, that's
Your-
fine.
your patient will typically have like these really big legs, like big tree trunk legs because of edema, and then a big belly, and then everything else is little. When a person has ascites, if they've got too much ascites, you can treat that by removing the fluid, and that's called paracentesis. So paracentesis, you're basically sticking a needle into their abdomen and letting water come out. I've seen them take 20 liters off of a person in one day. So, how many gallons is 20 liters? Well, how many quarts is that? It's about 44 quarts. How many quarts are in a gallon? 4. That's 11 gallons of fluid in their abdomen. How many have ever carried a 5-gallon bucket? Pretty heavy, right?
Mm-hmm.
Yeah. Okay, so, yeah.
The next day, it fills right back up again. A lot of it.
Yeah. Now, one of the things you have to be careful about when you do paracentesis is that fluid is compressing their arteries. So it's helping to raise their blood pressure. And if you take it off too quickly, their blood pressure can drop. When they get into this state, really there's only one true treatment, and that's a liver transplant. In order to be eligible for liver transplant, they have to not do any drugs or alcohol for I don't know how many years, but doing that will take you off the list. And I've got a video that I'm supposed to show you, but this particular room doesn't have good video capabilities, so if you ask nicely, maybe I'll post it on YouTube, on What's it called?
This is a point.
On canvas. I don't have it on that computer. Yeah.
This is
All right. Any questions about liver failure? Portal hypertension. Do you need another break?
I feel like
This
I
one.
need another break. But I want to get sleep.
I want to be done.
Yeah, sure.
how much more do we have for
For GI?
yeah.
We've got probably another 15 minutes of GI.
Okay.
And then we'll
do
take a
that,
break.
And then we'll take a break. Okay.
All right. So next, we're going to move on to gallbladder.
Is it as rough as liver?
No. It's not as complicated as liver. All right. So we're going to draw things not to scale. So here's your liver, and then there's a little duct, and then there's a bag. And that bag is full of bile. What's the bag's name? The gallbladder. So what's another name for bile? Gall. Oh,
Really?
right. Yeah. Pfft, duh. And there's another name for bile as well, and that's cholera.
Oh, cool.
So sometimes the gallbladder is known as the cholecyst, which means bile bag. And what's a bladder?
Bag.
A bag. So bile bag, bag of bladder, gallbladder, it's all the same thing. So it's produced in your liver and then secreted through a number of biliary ducts into the gallbladder. Your gallbladder stores it until you eat a meal and then squirt some of it into the intestine. Does that make sense? Okay. Now, there's a common duct with the pancreas, which kind of swims all in and around here. So it's called the common bile duct. The common bile duct is shared with what other organ? The pancreas. So when you have an obstruction of the common bile duct, that also leads to an obstruction of the pancreas. The number one problem that happens with the gallbladder is inflammation, cholecystitis. The number one cause of cholecystitis, in turn, is gallstones. So what are the two major influences for cholecystitis? The number one is obesity. And the number two is alcohol, chronic alcohol in particular.
Is it?
So cholecystitis is gallstones?
In men, alcoholism is more common cause, and in women, obesity is more common cause. The classic pattern is a middle-aged, overweight female. However, you can also get it when you're young. And usually in a room this size, there is at least one woman who's had it by the time she's 20, 22 years old, who's not necessarily overweight. And I see a head nodding. So, yeah, almost always is at least one person who's had cholecystitis that requires a cholecystectomy. So, as far as treatment goes, we can have either conservative therapy, which is going to be keep the patient NPO, lose weight, reduce alcohol consumption, and then we've got aggressive therapy, which is going to be cut it out. And what's the fancy name for cutting it out? Cholecystectomy. Now, what is the purpose of bile in the first place? What is the purpose of bile in the first place?
To help break down foods.
To help what foods? What type of food in particular? Emulsify fats. So, bile is involved in the absorption of fats. when you don't have a gallbladder anymore because you cut it out, you don't have this nice little bolus of bile. Instead, you have kind of this small constant drip of bile. So for some patients, if they eat high-fat meal, that will result in fats not being emulsified and absorbed. So when it's not absorbed, what does it do? Comes out the other end. And that's known as steatorrhea or fatty diarrhea. And it's the 3 F's: frothy, foul-smelling, and floating. Frothy, foul-smelling, and floating. Yum. So, generally speaking, patients who have a cholecystectomy should avoid large high-fat meals. Some patients will say, but it doesn't matter to me. I can eat whatever I want. I don't have any problems. And you say to that person, well, I'm glad that it works for you. But that doesn't mean it works for every patient. Does that make sense? All right, any questions about gallbladder? All right, next we have pancreas. So, with pancreas, the two things we worry about is pancreatitis and pancreatitis. So the first one is acute and the second one is chronic. So for acute pancreatitis, usually what happens is we have a blockage of the common bile duct, which is going to lead to a backup of digestive enzymes. What are the two main enzymes that are types of enzymes that are released by the pancreas? Okay. Amylase and lipase. Now, what are your cell membranes made of? A phospholipid bilayer. Yeah, you guys like...
A hydrophilic cell and a hydrophobic core.
All right, so phospholipid bilayer. And what do you think lipase does to cell membranes? It digests them. So when the digestive enzymes can't get down that tract and they back up into the pancreas, what does it do to the pancreas? It autodigests. So acute pancreatitis is associated with autodigestion. So we learned when we talked about cholesterol that elevated triglycerides are associated with increased risk of pancreatitis. Gallstones are also associated with elevated risk of pancreatitis. And alcoholism is also associated with the increased risk of pancreatitis. I know.
Note everybody.
Also include triglycerides and alcohol.
Yep.
I felt so good when I walked in here this morning. I knew everything was fine, and now I feel so bad.
So when are pancreatic enzymes released? When a person eats. So the pain will typically be worse when a person eats. So in terms of treating acute pancreatitis, what do you think we need to do? Okay, keep the patient in PO and pain management. Treating the pain is the number one most important thing. And how are we going to treat the pain? Keep the patient in PO and
Give them pain medication.
Dilaudid, morphine. So yeah, opioid drugs. Then there's a number of other things you need to do, including treating the underlying cause. But the most important thing, keep them in PO, treat the pain.
So if they're MPO, does that then mean that they're TPN? Or...
Well, yeah, you're going to put them on TPN. All right. The next thing we have to worry about with pancreatitis is chronic pancreatitis. Now, what was the key word with acute? What's the disease process? No, what's the disease process?
Backup of digestion.
Yes, the backup of stuff causes autodigestion. So the pancreas is like eating itself. In the case of chronic pancreatitis, that is not what happens. In chronic pancreatitis, we have a replacement of parenchyma. What's parenchyma mean? Functional tissue with what? Fibrotic tissue, which is a fancy way of saying scar tissue. The driving factor for chronic pancreatitis is chronic inflammation. That can be from a number of things. It can be from alcohol. It can be from gallstones. It can be from cystic fibrosis. Those are kind of the big three. But whatever the reason, over time you're having less functional tissue. What does that mean for your digestion? Your digestion will be lower because you don't have as many enzymes being produced. So patients will often need to take digestive enzyme supplements. There's typically also going to be a good amount of pain that needs to be managed. And the last consideration is increased risk of pancreatic cancer. Now here's the tricksy part. Chronic inflammation can cause cancer. But guess what cancer causes? Chronic inflammation. So this is what we call a chicken and egg problem. So some patients have pancreatic cancer because they have chronic inflammation. And others will have chronic inflammation because of the cancer. So you can have spontaneous cancer that results in chronic pancreatitis, or you can have chronic pancreatitis that results in cancer. Either way, pancreatic cancer is one of the most deadly cancers that we know of.